Great. So thank you for all your questions that have been coming in, and in no particular order, we will. Well, some of you may chip in at any one time if you've got additional answers to help. But Richard, migraine and vestibular symptoms caused by concussion, or an underlying undiagnosed condition exaggerated or exacerbated by concussion?
Either or both. So we know that head injuries, people that have migraine, pre-existing migraine, are more likely to get prolonged symptoms following a concussion, and they're quite often migrainous. But I have many people that didn't ever have a migraine before. They probably have an underlying genetic susceptibility, but we don't test for genetics of migraine. Vestibular problems, again, lots of people, vestibular problems are quite common, things like BPPV and labyrinthitis, and people that have had those before often get symptoms afterwards. But I think head injury is a very well recognized cause of damage to the inner ear and the vestibular apparatus. Things are also complicated with vestibular migraine. Some people, the kind of obsessional vestibular aficionados and the obsessional headache doctors argue between themselves at great length whether it's all migraine or all vestibular, what chicken and egg. The bottom line is I treat both in the vast majority of patients that present with headache, environmental sensitivity, and vestibular symptoms. So you treat the migraine and you treat the vestibular problems with physio, and it tends to get better.
Great. Just to follow up on this, you mentioned several times the graduated return to play, but does the fitness or the level of the athlete dictate the accelerated speed? So the fitter you are, the actually quicker you can return compared to someone who's very unfit, is a weekend warrior, Sunday league football, and has taken a bang?
Well, I think it probably not, because you're getting back to your previous level. So we wouldn't expect a very unfit person to be, it's all relative. So the graduated return to play doesn't really stipulate the amount of exercise. It's at what you were doing before. I think it can be complicated by, sometimes we see people with prolonged recovery who lose a lot of their fitness, and then they start doing some exercise and feel pretty awful, and you don't quite know whether that's symptom recurrence or lack of fitness.
Okay, I'm going to rattle through these because there's quite a lot of them. So age is a factor in your clinic. So dealing with a pediatric athlete and the worried parent, are you more conservative in your recommendations of 3 to 4 weeks off, or get them exercising at day 1, day 2, day 3? How do you manage that conversation, particularly around exams and school pressures?
Yeah, I think probably are a bit more conservative. I mean, there are concerns about the impact that these sorts of injuries can have on brain development as well as brain function. And I think I've got a lot of kids who have an injury at a really crucial time. The week before their GCSEs or before their interviews for university. So we try and be practical and work around that. And I always say to non-professional sports people that the aim for them is to get back to what they're earning money or what their main thing is. And with kids, they might not like it, but it's education, and that takes priority over returning to sport, in my view.
So just to follow up on that, and we've discussed this lots, and many of the audience make reference to this. If you are a specialist centre, have been dealing with this for almost a decade, how do we expand concussion expertise nationally? What sort of government support is there? How do we get out of our siloed thinking in managing this?
Well, it's a very good question. So there is a plan to have 12 regional concussion centres in throughout England, and the first is going to be in Cambridge, and it's going to be opening very soon. And they're essentially modelled on a similar model to what we've been in at ISEH. I think the key for me though is not, the difficult prolonged symptoms issues are always going to need a bit more specialist care. But I think that the vast majority of people, it's not really hard. They don't need super specialist care. And I think I've been trying for many years to try and raise awareness that it isn't super difficult and could be managed in primary care by a number of other doctors and physios. And I think as people become more aware that is being done, I still think that the term concussion and post-concussion syndrome are holding us back, because I think they add a whole load of mystery to what isn't that mysterious.
We're moving now onto the pitch. So I assume some sports medics and physios are asking these. So in terms of the acute pitch side setting, what will be your criteria, Dave, all the others, for the presentation of signs and symptoms that would warrant CT imaging?
Maybe one for Richard. That actually is. When would you want it, CT imaging acute?
So I think if there's loss of consciousness for any period of time over a few seconds, if people have a significant period of amnesia, so more than a few minutes, if there's any prolonged change in behavior, drowsiness, vomiting, I think that a lot of people go to A&E and then they use the NICE criteria. I think the rate of CT abnormalities in sports-related head injury is pretty low overall, but I am sometimes surprised that people weren't taken to A&E. If the injury would have occurred in another setting at work, they would have gone to A&E, I think.
Matt, maybe I can just make a kind of follow-up comment. So it is an area that lots of people are interested in, the use of blood biomarkers within. So it's very tempting to think that if we could get something working that could either be done very quickly or a pitch side, with the kind of biomarkers, the blood test that I told you about, that would be very useful. And there's currently a big application to run a clinical trial of blood biomarkers specifically to see whether or not you need to do a CT scan. So the idea is that you do a blood biomarker. If it was low, then we wouldn't need to do a CT scan. So I think that's probably where we might end.
And they're already licensed in the US for that. It's not. It is in clinical use, just not in Europe.
And just on that, then, I've seen a couple of your papers, Dave, with some of the professional rugby clubs looking at salivary markers. Are we still pursuing down this avenue of research, or is it blood's the way forward?
So Tony Belly in Birmingham has been focused on testing of salivary biomarkers, particularly microRNA measures. So the idea is that you'd be able to do a salivary test. That's obviously very attractive, not having to do blood tests at pitch side. And the RFU have been very supportive of that work. I think it's not yet proven whether those salivary microRNA tests are specific enough to be useful, but we'll see in due course, I think, with additional studies.
And in terms of the time frame for these blood tests, is there an optimal window at when you should be taking the blood and analysing it?
Yeah, it's a good question. They have slightly different time courses. So the one that I showed you data on, neurofilament light, kind of peaks probably about 7 to 10 days, but most of the other ones peak much more quickly. So they elevate. The peak is probably within the first 24 hours, and they're up very, very quickly. So if you do blood tests of things like GFAP in the first hour or two in A&E, it will be elevated, and that will tell you, to some extent, whether there's been an injury. So that they're there early enough in the blood to be informative and useful in my view.
Okay. And then in terms of mouthguards, which I know several of the federations and international federations are investing heavily in terms of your clinical worlds, the military, blast injuries, services. Are you seeing much utility for and association with the forces generated in the instrumented mouth guards with brain imaging?
Yeah, so maybe I'll just comment on that. So I think that's a dramatic step forward, actually. So I think that for example, the RFU have supported, the deployment of mouth guards quite widely in the professional game. And what that gives us is a measurement of not just whether somebody has a concussion or not, but what the number of hits above a certain threshold is. And as Richard said, in my view, I think it's really about the cumulative exposure, not the symptoms, but actually the biomechanical exposure over weeks and months and years. And what we need to do is to keep track on that, ideally for an individual. So what a mouth guard does for an individual is it gives them their own exposure over time. I think what we're missing at the moment is an idea of where the threshold is. So where is the where is the force above which we should be worried? Because obviously lots of times you have very minor head knocks that are probably not important, and so what we need to do is understand the relationship between the biomechanical force measured by the mouth guard and the likelihood of neurological problems.
And then just relating one of my questions just to the SWI in athletes and the microbleeds, is that validated in a cohort of individuals, or is there projects looking at those that have a symptomatic versus absolutely no symptoms whatsoever? Do we see micro brain bleeds in contact sport athletes that are completely symptomless?
So we have done one relatively small study on this in elite rugby players, and what we found was just under 25% of active elite rugby players showed some abnormality within either diffusion or susceptibility weighted imaging. It was much more common in the diffusion though, and actually the SWI microbleed abnormalities are probably less than 5%. I mean, Richard would say probably 1 or 2%. So relatively small numbers, and you have to get, I think, up to quite a significant head impact to have a high likelihood of producing microbleeds. Would you agree with that?
Yeah, I'd agree, but I'd also say that these changes can have happened at any time from sort of childhood to mid-20s, any exposure, and the vast majority of time we pick these up, they're asymptomatic, or at least incredibly subtle symptom-wise. And one very difficult area is that when you do pick up these sorts of abnormalities in active players, having a conversation about their risk of continuing when there is what we know is clear evidence of fairly significant trauma to the brain, even though they're fine, they feel fine, they're training, they're playing well, the coach is very happy with their performance. And we don't know whether they've been walking around with these abnormalities for years. It's a very tricky conversation.
I'm just very conscious of time because I'm given the time warning that we're almost up. 3 questions here related to family history of dementia and also MND and Parkinson's. So does a family history increase the risk of a contact sport athlete developing a brain health issue in future years?
I'm not sure we've got masses of epidemiology on this, but I mean, there's some data that suggests that that ApoE, for example, one of the main genetic mutations that can be associated with the sort of sporadic late onset Alzheimer's disease, is kind of overrepresented in CTE case series. So having a propensity, family history of these other problems, and we've talked about kind of co-pathologies, multiple different problems that present. So I think it's probably puts one at slightly greater risk, but I don't think there's good epidemiology across most of these things. And many people with kind of a family history of dementia, unless it's a very strong kind of autosomal dominant type dementia syndrome, have kind of many, a number of kind of small risk loci across the genome that perhaps add up together to contribute to things. So I think there's a lot of work to be done on the kind of interaction between the environmental exposure and someone's kind of pre-existing genetic propensity. And there are some interesting ways of doing that, which would include looking at family history, as well as some things like kind of genetic risk scores, which add up a range of kind of low risk loci together across conditions such as Parkinson's, MND, or Alzheimer's, and relating that to the kind of brain health consequences.
Maybe just make a comment on that, Matt, as well. So I think where we're going, I think in the end, we will be screening in some way by combining a genetic risk factor, with some of these other measures like a blood test. So it is true that we're understanding more and more about the genetics of these things. And in my view, there's an interaction between the two. I mean, one specific example is around Parkinson's risk. So Parkinson's risk, is only increased in TBI with a particular synuclein genotype, according to one study. So that's a good example of where there's an interaction between your genotype and your risk of TBI exposure.
Good. And if you give me one more question, because I know time's up, but the role of medication in prolonged concussion. There's a lot of individuals here that have seen quite a lot of prolonged medication use amongst athletes. Is there evidence to support this or consensus amongst the group prescribing?
It depends which medication. So I think for specific treatments, such as treatment of migraine, there's pretty good evidence that post-traumatic migraine responds to amitriptyline. It's the only thing that's been studied. But in my experience, other migraine treatments work very well. I think that antidepressants work very well for depression, but I don't think there's much evidence that. I mean, I'm not quite sure what other medications are used.
No, fair enough. I should have found out more details before I asked it. So that's it. Time is up. Lots of people are asking whether these slides are going to be available, and yes, they are. Like all ISEH education, it remains free. We're very proactive in creating free content. This will be uploaded onto our YouTube channel and onto our social media channels, and we would like you to distribute it far and wide. We don't want this siloed approach. We can try and disseminate this lecture to as many people as possible, as many parents as possible. I will be delighted. I would like to thank Neil, David, and Richard for their time this evening. I'd like to thank the audience for attending, donating their evening on a Monday. I very much appreciate that. This concludes night 1 of 2. Tomorrow night we have hip and groin pain in athletes, led by Professor Haddad, who's the clinical director of ISEH and orthopedic consultant at the Princess Grace Hospital at HCA. So thank you very much. Thank you, gentlemen, and thank you to the IT wizards in the background. Have a great evening.